Participants will be muted upon entry and videos turned off for the technical assistance. Please use the chat. We will try to respond to your needs. And participants will receive a link to the presentation slides and a recording via email after the webinar. We can move on to the next slide. I'd like to start out by introducing my colleague, Dr. Jean Doak. Jean, do you want to do a quick rundown of your background?
Sure. Good afternoon and good morning to everyone participating in this first webinar. We're very excited to have y'all here. As Jeff indicated, my name is Jean Doak. I am a psychologist and clinical director at UNC Center of Excellence for Eating Disorders. And I work with Guidehouse to provide technical assistance in the Center of Excellence for Eating Disorders for SAMHSA's organization.
Great. And as you can see, I'm Dr. Jeff Greenberg. I'm a clinical psychologist as well. I have been working in federal behavioral health for almost 20 years now, and I'm the project director for SAMHSA's Eating Disorder Center of Excellence. We'll move on. Quickly going through the agenda and learning objectives. As you can see, we'll be going through an introduction, the roles of primary and community care, quick facts, an overview of eating disorders. We'll be taking you through a patient journey from an actual real-life patient scenario, the three-step model for screening, identification, and referral, tools and tips, recap, and closeout, and Q&A. We'll be presenting resources and upcoming events, including our future webinars, which we hope people will take the time to attend. The objectives, the entire purpose of this project is to increase awareness of eating disorders and help people understand why they're important in primary care settings. Review the journey through prevention, treatment, and referral to care. One of the things we'll be talking about and we focus a lot on is early identification, early intervention, which is the time when it is the best outcomes are associated. And then providing tools and resources, tips to take away for real-world application. Our hope is that you will be able to apply what you get today in your practices and hopefully make differences in the lives of those you provide care for. Next. As you can see, our mission, we will be providing webinars throughout the course of the remainder of the year. We'll have peer-to-peer communities. We'll have some more information on that a little bit later. We'll be providing tailored resources, and we are currently in developing our comprehensive website, which we will make all aware of when it's actually up and running. Just want to start out with a quick poll in terms of eating disorders. If you feel comfortable, please put your responses. Sorry about that. If people wouldn't mind responding to this introductory poll question. Thank you. Give another minute or so to get this, to get these responses. We're getting some last minute responses. All right. Dr. Duke, you want to present the accurate answer to that? So we can tell you that,
Jean, Jean is muted.
Yes, so I don't have the previous question in front of me, but I believe yes, thank you very much. So which of the following statements are true? It looks like the overwhelming majority picked the correct responses. Those are B, C, and E. Eating disorders have the second highest mortality rate of all behavioral health conditions. That is correct. C, people with eating disorders can appear physically healthy within weight recommendations. That too is correct. And E, primary care clinics are important to prevention, early identification, and early interventions for eating disorders. Hence, one of the reasons why we're providing this webinar today. So those are the 3 correct responses.
great, thank you. All right. We can move on to the next slide. So we are very fortunate today to have our presenter, Dr. Leslie Williams. We'll have Dr. Williams introduce herself and her background in just a second, but just for everyone's awareness, Dr. Williams is a nationally recognized eating disorder expert who works out of the Mayo Clinic. Dr. Williams, the floor is yours.
All right. Well, welcome, welcome. Thank you all so much for being here. I am just delighted for the opportunity to share with you today. As was already mentioned, I am a board certified family medicine physician and expert in eating disorders. I've been working in the field for around 20 years. Although I love working in eating disorders, I'm super excited about prevention. And so I'm thrilled that you are all here today to talk about that important topic, because ideally, I would love for the job of an eating disorder expert to be eliminated, because we've eliminated eating disorders. In terms of my work, I serve on the board of directors for the Academy for Eating Disorders, and I have a lot of professional passions, but one of the things that I really am an advocate for is health equity and weight inclusion. And we're going to talk about that some throughout our time today. So let's go ahead and get started. Next slide, please. So your understanding, involvement, and advocacy is vital to addressing eating disorders. And I'm just thrilled that you all have taken the time to share with us today, because this is the first step, right? Learning more, figuring out how we can recognize these eating disorders and get people the help that they need in an appropriate time. Next slide. So we know that primary care settings are on the front lines of early identification. And I think for too long, the idea of treating and addressing eating disorders has been thought to be siloed in some super specialty area, but really we're the ones working in the primary care clinics. We see this every day. And so we know that we want to kind of be attuned to when we see this and be able to intervene before things get so severe that someone needs that higher level of super specialized care. Next slide, please. So what's important for you to know about eating disorders? So definitely screening is important. Knowing when to knowing when to ask the right questions, because patients very rarely present to a primary care clinic saying, I think I have an eating disorder. And I will say, with the evolution of GLP-1s and their use for weight management, it has really offered an opportunity to open the door to a lot of these conversations, because patients may come in asking for these medications, whether or not they even meet criteria for these medications. And so it has provided kind of a new door for me to be able to have some of these conversations. We recognize that there's a lot of misconceptions around eating disorders, that so often the image of an eating disorder is someone who's super emaciated. And we recognize that eating disorders do not have a shape, a size, ethnic background, a cultural background, that they occur in all different people. And so we need to step away from this idea of, well, they don't look like they have an eating disorder, because there is no particular look. And so there's so many people that are out there that are struggling. And the more we educate ourselves and open up the door to these conversations, the more we'll be able to provide that help and really reduce the stigma and shame. Oftentimes there's this idea that, you know, eating disorders are just out of vanity, or, you know, or they demonstrate a lack of self-control. And so there's a lot of stigma and shame about bringing forth these concerns. And so the more we kind of get out there and have conversations and really kind of, you know, make it understood to the patients that we serve that, hey, it's pretty typical for people to struggle with concerns about weight, shape, their body, what they eat, especially living in the society that we live in, because we're surrounded by messages around this all the time. And so we want to create that safe space where people feel comfortable kind of chatting about some of those concerns. And then we want to be able to recognize the signs and symptoms when disordered eating has gotten to the point that it, you know, really is starting to interfere with someone's physical health. We want to be able to see that and really kind of pick up on those things. And then be aware of the treatment options. We're going to talk about some of the challenges with helping patients find treatment, which I'm sure those of you that are out there in the trenches already are aware of. But we want to familiarize ourselves with the different options and how we can help people get the care that they need and help kind of streamline that referral process. Next slide, please. So first, we're going to go through some quick facts about eating disorders. And our little poll was kind of a preview into this. So next slide, please. So we know that eating disorders are not a harmless condition, that they result in over 10,000 deaths annually. So that's one death every 52 minutes. So that's going to be one death that occurs in the time that we're spending together today. Next slide. And we know that eating disorders have the second highest mortality rate of any psychiatric illness. And frequently, a lot of that mortality is around the suicidality, because patients who struggle with long-term eating disorders feel so helpless and hopeless about the potential for recovery. And as we talk about treatment options, I hope that you will see that there is hope for recovery, and we want to help patients be able to see that as well. Next slide, please. 9% of the US population will struggle with some type of eating disorder throughout their lifetime. And so that's important for us to recognize, is that this is not something that is, you know, rare. And it is very common that throughout someone's lifetime, they will struggle. And ideally, we want to be able to really help support them. Next slide. And what's really important for us to emphasize is that only about 20% of those with an eating disorder ever receive treatment. And that's back to what we talked about a little bit earlier. There's a lot of stigma involved. Patients are fearful of coming forward. And we also know that oftentimes they kind of fly under the radar, because there has been a misconception that eating disorders have a particular look or a particular demographic. And so despite the large number of people that are struggling, there's a small percentage that ever get care. And so that's one thing that we're hoping that through this type of work with SAMHSA, we can kind of close that gap. Next slide, please. We also know that eating disorders are extremely costly. Not only do they cost in terms of the medical morbidity and mortality, but they're also very costly from a financial perspective. And it's been estimated about $64.7 billion a year are utilized on services and support for those that struggle with eating disorders. And a huge portion of that is spent on inpatient hospitalizations. So back to one of our primary points today is that if we can intervene before someone gets to the point where they need this costly inpatient treatment that maybe isn't even available to them because of whatever insurance coverage they have or other obligations, that we want to be able to get them help. And we know that 29.3 million is spent on emergency room visits alone for issues related to eating disorders. Next slide. There are a lot of common myths about eating disorders, and we want to bust some of those myths today. So we've already mentioned that people at a normal weight cannot have an eating disorder, and we've already noted that that is not accurate. We're going to go through all of the eating disorder diagnoses, and they can happen along the weight spectrum. And so we know that weight does not reflect disordered eating behaviors. There's also a misconception that young people grow out of having an eating disorder, and oftentimes that's not the case at all, that these eating disorders can persist at different levels throughout our lifetime. And we know that there's certain times of vulnerability, adolescence, adulthood. There's different times when these eating disorder symptoms can resurface. We know that getting getting healthy is just about eating more or less, and that is not accurate. As we've already stated, that health comes in all different shapes and sizes, and I'm a huge supporter of the whole health at every size and weight inclusivity movement. And that's one thing that's a challenge within the medical field today, is that there's still a lot of kind of evolving thinking about this idea that if someone gets to a certain size, they're automatically healthy. That's not necessarily the case. And we really want to impart upon people that, health promoting behaviors can happen at all different shapes and sizes. And there's another misconception that after someone who does make it to inpatient care finishes that course of care, they're cured, they're done, they don't need any more support. And as we've already talked about, eating disorder symptoms can wax and wane over someone's lifetime, and they will often need ongoing support. And again, we've already mentioned that eating disorders are not about vanity. They're not about getting attention. There's so many other things behind an eating disorder that drive an eating disorder. We'll talk about some of that today. And I think that there's a lot of stigma involved because of this misconception that it's just something of vanity. And people with eating disorders are punishing parents or loved ones, and that is absolutely not the case. We know that eating disorders do impact the entire family system because they can be so pervasive in terms of how they show up, but it's not about a power struggle. It's really about that one person and the struggle that they're having, and just recognizing that the whole family system can be impacted. And they are not a lifestyle choice. Like, eating disorders are truly a psychiatric illness that requires appropriate consideration and care. And parents are not the cause of eating disorders. There's so many different factors: genetics, society, as we mentioned, despite how supportive parents can be, and just a lot of other underlying issues that can impact the development of an eating disorder. And so this is not about a blame game in terms of parents being the source, but we do know that weight stigma, regardless of where it comes from, be it in the family, in society, in school, can be a potential catalyst for development of an eating disorder. Next slide, please. So what do we know? What is true about eating disorders? As we've already said, it's kind of the opposite of some of those myths. Families are not to blame. And in order for us to really beat an eating disorder, the whole family system, we need to work together as a team, as allies, in order to get the appropriate care. We know that once we have diagnosed someone with an eating disorder, it is a health crisis that can impact that entire family system. And so it does require that multifactorial, everyone dialed in to help the person get the support that they need. And this is not a choice, but there's a lot of social and biological influences that lead to eating disorder development. And genes are just one aspect of that, but alone they do not predict who will and who will not have an eating disorder. As we've already stated, just looking at someone is not a reflection of what their eating disorder status may or may not be. And we know that there's a high risk of suicide, as we mentioned, back to the risks of mortality. And there's also the risk of medical complications that can lead to a host of medical issues, up to and including death. We know that genes and environment are both factors in the development of eating disorders, and that full recovery is possible. And you all play a huge role in that early detection in order for us to get to full recovery. Next slide, please. So we're going to go through the journey of a patient who might be struggling with an eating disorder looks like within a primary care setting. Next slide, please. So I'm going to give an example of a patient scenario. We have our patient, Regina. She's 5'4", 190 pounds. She's 38 years old. She works as a high-level administrative position in a large community organization. She's been treated by your clinic for hypertension and high cholesterol over the past 5 years. And now she's presenting with new complaints of back and knee pain, which is really impacting her ability to be physically active and has really impacted her issues in terms of weight gain. We know that she's had a lot of weight fluctuations, especially since college. She recalls that in the past, she was on an average of about 135 pounds. And then by college graduation, her weight had gone up to 160 pounds. And since then, she struggled with lots of fluctuations with weight. She's been on a number of different diets, tried different things, but nothing has really been successful. And now she's coming to you because now this weight is at the point where it's really impacting some of these physical symptoms like her back and knee pain. And she states that in the past, when she's presented to doctors, they've always said, eat less and exercise more. Next slide, please. So let's talk about Regina's journey through primary care. So we know that it starts with that initial visit. She presents saying that she's having some health issues. She feels that weight is a struggle for her and she doesn't know where to turn. She's tried all kinds of things. She's done Weight Watchers. She's done all the things and she's getting really frustrated. And she's really noting that it's having an impact on not only her physical health, but her mental health. So as the primary care provider reviews Regina's chart, goes through all of her medical history and all of the things that have happened to date. And then this is the opportunity for them to really dial in and ask more questions about her stressors, her mood, and most importantly, her eating patterns. What we find through dialing in and asking more of those questions of Regina is that she reveals that she has really struggled with overeating in the past. She has tried to bring this up to therapists in the past, but they've kind of just dismissed her and told her that, you need to practice more self-control, things of that nature. And she really just felt like she didn't have that empathetic ear. When we get more information, we find out that she's really struggled with loss. She's lost a family member in the past, and that loss and the grief associated with it was definitely a catalyst to some of her overeating behaviors. But despite this, in the past, when she's brought this up, it really wasn't the focus of the work that they were doing therapeutically. And as a result, she really just became embarrassed to bring up her eating behaviors. And she subsequently stopped going to therapy and never really brought it up again. So now, in the comfort of your office, and because you've opened up this conversation to really learn more about Regina's history of emotional eating and how that's impacted her ability to really be successful with lifestyle changes, she feels validated. Regina feels heard. And most importantly, she doesn't feel judged. In the past, she's always felt like, from a primary care perspective, that the staff and the provider were just kind of rolling their eyes in terms of her struggles, and they weren't really seeing her as an individual and what she's gone through. She was screened for an eating disorder, and her screener ended up being positive to demonstrate that she does have disordered eating behaviors. And so now we're going to shift to this being a team approach, right? We know that this isn't just a send Regina home with a magic pill or intervention, but she needs help. She needs, first and foremost, psychoeducation about what eating disorders are, how they show up, different things that can happen within our life that can be a catalyst. She also needs to know that there's treatment out there that's available to her. We want her to meet with a dietitian that specializes in eating disorders. Historically, she's tried to meet with dietitians in the past, and they've always just kind of told her that she needs to eat less and given her a food pyramid, but she needs someone to understand about these disordered eating behaviors and how they impact her ability to be successful. We want her to meet with a therapist to talk about this past trauma, the grief that she struggled with, and to really equip Regina with tools, right? Historically, she's always turned to overeating as a way for her to navigate when things were challenging from an emotional perspective. But now, if we can get her to find a therapist that really understands her and can help equip her with appropriate tools, and we recognize that, hey, this is a pattern of behavior that has served you well to deal with a lot of the stress and the trauma that you've had over your life. But now we see that this has gotten to the point of disordered eating behaviors, and we want to help you to kind of, you know, not have your emotions and your eating behaviors be so intertwined, but to work on eating what's appropriate for your body. And when you feel emotions, recognizing that and utilizing the appropriate therapeutic tools to navigate that. So for the first time ever, Regina feels like she is empowered, that she is not fearful of coming into her doctor's office and the fact that the number on the scale may have gone up and how that's going to be impacted. And part of our other aspect of the treatment plan sometimes is to maybe kind of dial down how frequently we're weighing Regina because there's so much emotion tied into that. Or maybe doing blind weights so that she doesn't feel a sense of success or failure that is just tied to the number on the scale. And so this is a scenario that I go through time and time again in my office. And it's just one reflection of how eating disorders can show up in a package that maybe is not what we've historically been taught that they look like. Next slide, please. So as a result of this compassionate care, Regina has received the appropriate level of treatment that she needs. She's been provided with a safe space to express her concerns, and she feels relief. No longer is she being looked at someone who lacks willpower, but she's being seen as having a problem that is treatable, and she is just excited about the potential for recovery. Next slide, please. So we're going to chat about a 3-step model to really help patients kickstart treatment. And the first step in that model is the screening process. We know how important it is for us to recognize when patients may or may not be struggling and to be able to screen to see if there's some underlying eating disorder behaviors. And so that awareness really is key in prevention because oftentimes they may not even rise to the level of having eating disorder, but they may be vulnerable. And we want to be aware of that and be able to provide that appropriate support. If we do recognize that someone has an eating disorder or is vulnerable to development of one, we want to know how to have those conversations. How do we kind of tread lightly and be able to provide them with different treatment options and talk about overall treatment goals. And then we want to look at the referral process. And we know that that can be challenging, especially depending on where you might be practicing within the country or the world. And so we know that it's not always possible for us to be able to provide that comprehensive care within the context of our clinic. But we want to know what patients need to be referred and how we can find specialists that we can reach out to. Next slide, please. So screening, as we've mentioned, screening is so important. There's so many different opportunities. I think that there is even some thought that there's the potential for just screening universally within community settings because we know how common eating disorders show up. Next slide, please. So it's really important for us to establish a baseline understanding of eating disorders and what to look for so we know about screening and we can really intervene and provide that early identification. So it's really important to ask the right questions to know what those are and to be able to diagnose those people that meet criteria for an eating disorder. And then if they do meet criteria, recognizing what is the appropriate level of treatment for that individual. Next slide, please. So as we've mentioned earlier on in the talk, eating disorders have a variety of different diagnoses. And so the most common diagnoses within the context of eating disorders is other specified feeding and eating disorder, or OSFED. And we know that this is an eating disorder that it doesn't meet the full criteria of some of the other disorders that we're going to go over today, but the patient is engaged in disordered eating behaviors. And so this is one that is kind of like that catch-all phrase, especially if you're not necessarily 100% comfortable saying, oh, I don't know what bucket it fits into, but I know that this person is struggling. OSFED is a good kind of diagnosis that we can put on the chart to reflect that they're really having struggles, but it may not raise to the level of the DSM-5 criteria for some of these other eating disorders. The other very common eating disorder, which we chatted about some with our case, Regina, is binge eating disorders. And that's a patient who engages in binge eating behaviors. Typically, that's eating a large volume of food within a short period of time, having a lot of emotional distress over their eating behaviors, maybe at times eating to the point where they have physical discomfort and feeling a sense of a lack of control over their eating. And to meet the full criteria, it also looks at how frequently this is occurring and how much emotional or psychological distress the patient is experiencing as a result of this. The other more classic eating disorder in terms of what we think of that has been previously kind of highlighted within the public media space is anorexia nervosa. And that is a patient that struggles with an intense fear of gaining weight. As a result, they engage in severe caloric restriction. Sometimes they might engage in some other behaviors like overexercise or purging in order to keep their weight at a very low level. And they have, again, a host of medical complications that can go along with that. So typically when people think eating disorders, they think anorexia, but what we know about eating disorders within our society is that anorexia is probably the most well known, but it occurs the least frequently as compared with some of these other eating disorders we're discussing. The next eating disorder is bulimia nervosa, and those are patients that engage in some type of binge eating behavior, as we discussed with binge eating disorder, but then they also engage in some type of compensatory mechanism. So after they engage in binge eating, they do something in their minds to try and compensate for that extra amount that they took in. That can come in the form of restriction, so going long periods of time without eating. It can come in the form of overexercise, and it can come in the form of purging, either via vomiting or laxatives. And then the other kind of newest eating disorder category, and one that I'm seeing quite a bit in my practice, is the avoidant restrictive food intake disorder, or ARFID. And those are patients that have some type of alteration in their eating to the point where they're not meeting their nutritional needs. And that can come from a variety of different sources. For instance, it could be a patient that struggles with textures. Maybe they're on the autism spectrum. They're very selective in the foods that they feel comfortable eating, and their foods as a result have become so narrow that it is impacting their overall health and nutritional status. What I see more frequently in my practice are patients that have some kind of overlapping gastrointestinal symptoms or complaints, which subsequently causes them to be very restrictive in their food. And as a result, they start having all these signs and symptoms of malnutrition because they're not able to maintain adequate nutritional intake because of fear of how that might manifest in terms of gastrointestinal symptoms. So that's just an overview of some of the common types of eating disorders. We know that this list is not exhaustive, and for a full list, you can refer to the DSM-5 TR. Next slide, please. So things that we want to look for in terms of warning signs. Those that are overly preoccupied with food, weight, and shape. If you notice any dramatic changes in terms of very dramatic weight loss or weight gain, maybe utilization of over-the-counter diet pills, laxatives, diuretics, or emetics. And emetics are those items that cause one to vomit. Denial of how severe the illness is. So maybe a patient who's gotten, like recently had a patient whose weight had gotten down to 85 pounds as a male, and he was saying that he had no body image concerns, but also was not seeming to understand the severity of the situation when his baseline weight was like 180. Medical complications that can manifest are symptoms like dizziness, fainting, easy bruising, hair loss, brittle hair and nails, osteoporosis, diarrhea, constipation, and dental problems. And as we mentioned, patients that are engaging in compensatory behaviors like purging or restriction, or those that might struggle with binge eating or compulsive eating. One aspect of disordered eating is patients that eat in secret, they hide food, they struggle to eat in front of others. They may feel out of control with food and be fearful about being engaged with food or eating out in a public space. And then those excessive or compulsive eating, exercise patterns. So those that are engaged in exercise despite the fact that they have an injury and other things. And in terms of individual risk factors, we know that transitional periods. So I've already mentioned adolescence, perimenopause is another time of transition. Patients that are maybe struggling with a medical condition, athletes can be another time, and patients with a family history of eating disorders. And we know that veterans are also vulnerable to disordered eating behaviors. Next slide, please. So this kind of goes through all of the common signs and symptoms, and I won't go through the list because it is quite intense, but we know that physical signs and symptoms can impact every system of the body, from the head to the toes. And so this is a list for you to peruse at your leisure. Next slide, please. Next slide, please. So intervention, next slide. So it's important for us to recognize when patients are struggling and then help them move forward to this next step of intervention and treatment. So medical treatment, our goals are to stabilize the patient, to make sure that we're able to help them improve their medical status. And next, in terms of nutrition rehabilitation, we want to help them to stabilize their weight. We want to get them on a more regular eating pattern. And we want to help them to have more diversity in terms of the foods that they're able to eat and really make sure they're getting all the nutrients that they require. And then another goal of treatment is normalization of eating behaviors. So we want to be able to reduce or stop any binge eating or purging behaviors, any restriction, any severe kind of behaviors that they have around food. And so those are some of the goals. And then lastly is psychosocial stabilization. So those where the eating disorder is really impacting them from a psychosocial standpoint, be it social engagement or their ability to, do any social activities because they're so overly concerned with their body image. Next slide, please. And then lastly is referral. So next, in terms of referral, we want to help patients find the appropriate level of care. One of the kind of hallmarks of eating disorder treatment is ideally finding the lowest level of care necessary for them to get the support they need. But if they're not able to show progress at that level of care, being able to step up and get them additional support. And so we want to look at the patient's preferences. We know that patients have a lot of other obligations in terms of family, work, and so forth. And so being able to find the appropriate level for them. And we want to be able to have ongoing continuing care coordination. So we know that we want to be able to find the appropriate care, but make sure that at all these different transitions that they have the support that they need. Next slide, please. So tools and tips. Next slide, please. So this is where we really want to help empower you all to implement this SBIRT approach to screening, brief intervention, and referral to treatment for those that may be struggling with an eating disorder. And we love this because it's comprehensive, it's integrated, it provides a public health approach, and it really helps us to intervene. So it allows us to screen patients early, be able to have the tools we need for brief intervention to help them with behavior change, and then get them to the right referral sources. Next slide, please. So utilizing the SBIRT ED, this is a quick and easy tool. It's really kind of built from these screening questions of, do you make yourself throw up because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 15 pounds in a 3-month period? Do you think you are fat even though others say you are too thin? And would you say that food dominates your life? So ideally, these are scripts that can be embedded within your primary care work. They are developed for use with adult patients, and we use them from the SCOFF screening questionnaire is the basis of them. Next slide, please. Our goal is that this is something that's so easy and accessible that it's something that you feel comfortable utilizing with all of your adult patients. And so this is just an example of what the SBIRT looks like. It's a very easy tool. You can use the link in the chat or scan this QR code to access the tool. And what I love about this is once you go through those screening questions with your patient, it will then give you some kind of red, yellow, green, whether this person is positive, high risk of eating disorder, whether there might be a medium risk for eating disorder or low level risk. And then it gives you some scripted prompts that really help empower you on how to respond to this patient, how you can express concern and what the next steps look like. And then embedded within the tool, there's also a referral guide to help that patient get to the next step that they need. And it's available publicly online. Next slide, please. And if you are in need of additional resources, there's a number of those that are available, and the NEDA website, as well as the Academy for Eating Disorders. And yes, for those that do screen positive for the SBIRT, if you do feel comfortable, the next line of screening might be to use something like the EDEQ, which can really help get into more of the details of their disordered eating behaviors. But ideally, we really want to focus on the SBIRT because it's something easy to use regardless of your comfort level, and it can really help you get them to someone who might feel more comfortable with something like the EDEQ. Next slide, please. So recap and close out. Next slide, please. So let's go over our lessons learned. All of us who work within a primary or community care setting play an important role in eating disorder prevention. We are often on the front lines, and we're the first people that patients might come to expressing some type of concern over their weight, their shape, or their eating patterns. We've reviewed all of the different spectrum of eating disorder diagnoses and the fact that there is a lot of stigma around patients coming forward. And historically, there's also been some stigma that has impacted clinicians recognizing eating disorders in patients. So we want to equip all of you with the screening, intervention, and referral tool within the SBIRT ED to really provide you with that strong foundation so that it improves your comfort level with being able to screen these patients and provide them with the brief intervention needed and get them to the referral sources that they require, but recognizing that this is an ongoing challenge within just the field at large in terms of finding mental health resources can be challenging. Next slide, please. So next steps. You've taken the most important step by being here today, equipping yourselves with the knowledge, learning more about this important topic, and we want the learning to continue. So please continue to seek out additional training opportunities. We really want to implore all of you to start using the Espert ED in your practice. The more you use it, the more comfortable you get, and you'll be surprised. I've even trialed this within my own primary care clinic, and there were a number of patients that when I started screening everyone that I had no idea, even though they know what I do, that they had never come forward. And the Espert ED really helped me to recognize those patients and give them the support that they need. We want you to review all of those other resources that we provided because there's a wealth of information that's out there that you can provide yourself with ongoing education. And please, please, please share this information and these resources with your peers because our goal, again, is to get to the point where everyone is knowledgeable about eating disorders, they feel comfortable screening, and hopefully we will get to the point where eating disorders are eliminated altogether. Next slide, please. So I would love for you guys to please rate your level of agreement with this statement. I learned something new about eating disorders today. And I think we're going to close out the poll and maybe open it up to questions. I have tons of questions, and I'm really excited to answer those.
Dr. Williams, I really want to take the time to thank you for what was been a very instructive and informative presentation. The first question that commented from our audience prior to the presentation is avoidance of eating in a social setting due to social anxiety a risk factor for an eating disorder?
That's an excellent question. I do think that that is a potential risk just because we know that patients with high anxiety are at a little bit higher risk of eating disorder development. And so, if their anxiety is to the point where it impedes their ability to be able to eat within a social setting, I would consider that a potential for risk factor and a patient that we would want to continue to kind of keep an eye on, monitor, and see if they need some additional support because that does show some impact in terms of their psychosocial functioning.
Great, thank you. How does eating disorders impact someone cognitively, from an organ function standpoint, and bowel movement, digestion standpoint?
Thank you so much for that question because I was kind of running low on time and kind of skirted through some of the medical complications. But from a cognitive standpoint, it can have a significant impact on cognitive function. I think one of my most severe cases that I had early on was a nurse who, in fact, had struggled with an eating disorder and severe malnutrition for so long and once we restored her weight, her cognitive function was not improving. And so we ended up getting imaging, and it really showed that she had atrophy or decreased size of her brain from the length of time that she had had severe malnutrition. And so that is an extreme case where there was irreversible damage from the extent of her eating disorder. But we know that patients who struggle with eating disorders can have, they discuss where they don't feel like they're firing on all cylinders. It can impact their cognition. From a GI perspective, that is a huge impact in terms of constipation symptoms, patients have slowing down of their gastric movement, which can impact like nausea. And it really can play a role when we're trying to help patients restore weight because they have a lot of GI discomfort as a result of the eating disorder. And now you're asking them to increase how much they're eating, which can sometimes increase their distress. And so we definitely, it's one of the examples of where it takes that multidisciplinary team to walk alongside that patient to help them meet their nutritional goals. And then it was cognitive, GI, and there was one other question I think about it.
About the organ function.
Oh, and organ function. So heart function definitely can be impacted by eating disorder behaviors, be it electrolyte imbalance from purging behaviors, for instance, or just decrease in heart size as a result of the malnutrition. So really, I feel like from a medical complications perspective, it can impact from head to toe and regardless of the eating disorder. As we went through all the different diagnoses, all of them have the potential for a physical impact on our bodies.
Great, thank you. Can you talk a little bit about how BMI categories affect eating disorder identification and diagnosis?
That is an excellent question and probably could be a whole talk in and of itself. So, as I mentioned, I come from the health at every size perspective. And I do think that within the medical community, us having such a focus on BMI and BMI categories versus a more holistic approach to health can potentially be a contributing factor to the development of eating disorders. For instance, you may have a patient that's on the higher level in terms of a BMI, but they're healthy. Their cholesterol levels are good, their blood pressure is great, their blood sugars are great, they exercise, but because it's been so ingrained that patients need to kind of fit into these specific BMI categories, they may feel that they're unhealthy because of where they are on the BMI track, and we're not looking at them from a holistic perspective. So I think that in some ways it could be a detriment, and actually the American Academy came out in terms of the medical provider governing body, and it's really trying to dial back our focus on BMIs because in a lot of ways it feels like it has been a disservice to patients because we're focused so much on that number versus like a more holistic look at health. So there's been more of a move away from kind of having BMIs be a surrogate for health because that's never how they were intended. It's just a math equation that unfortunately has evolved into being overemphasized.
Great, thank you. I'm gonna take the time to turn it over to our colleague, Dr. Doak, answer some of the questions that we've received in the chat.
Yes, thank you. So we have a few questions, Dr. Williams, and we're going to try to get through them in the next few minutes. The first one is related to developmental or risk for developing an eating disorder across the lifespan. And as you know through research, there are developmental points of time that may place an individual to be at greater risk. Relatedly, the question is, can you comment on eating disorders in menopause and perimenopause prevalence and treatment?
Absolutely. This is one of my topics that I love because it is definitely under-recognized. So we've already discussed that at transitional periods, and I think we don't recognize enough how much perimenopause can be a transitional period. Much like adolescence, the same thing is happening. There's hormonal fluctuations that are happening within women that are causing changes in their body that are completely outside of their control. And again, there's this kind of push from a society perspective of, that you need to do something to stop that. And oftentimes women feel this need to restrict their intake or overexercise or do something to kind of change what's happening with their body. And there's not enough conversation, I think, especially on the primary care setting, really equipping women to understand what's happening, what's going to go on with their bodies, things that they can do that are helpful and things that they can do that are detrimental. So I definitely think the perimenopausal period is a real position of vulnerability. And just from a psychosocial perspective, at the same time that all these body changes that are happening that are outside of someone's control, even when their food intake and their exercise hasn't changed, their roles within their family, their kids are getting older, so many other things are changing, their friends might be having health issues, which has not been something that they've experienced in the past. So it's definitely a period of vulnerability and a real opportunity when we see women that are getting close to that age frame to kind of open up the conversation, right? Because we know that it's something that's so common that we don't need to wait until they're having symptoms and come to us. We can say, hey, sounds like you're getting closer to that. I call it the perimenopausal season. These are some of the things that women experience. You may not be experiencing them now, but if you start having these symptoms in the future, please don't hesitate to reach out to me so we can talk about that in more detail.
Thank you for that detailed response. And I really appreciate the question that was submitted around this, because this is related to several of the slides where you discuss how anyone who presents in anyone's office can have an eating disorder. So this is an example of a patient that would go against the stereotype of what we would expect to see with an eating disorder. So thank you for submitting that question. Earlier in the chat, someone mentioned being located in a treatment desert. And so the second question references that. And the question is, what can a registered dietitian without eating disorder treatment, training or experience, do in a treatment desert? What training is recommended for registered dietitians to provide actual eating disorder treatment?
Thank you so much for that question. And I've referenced this throughout the talk, and I know that it is a true issue, is being able to find that appropriate care. So you're already taking the first step by coming to this talk today to really kind of increase your knowledge. And there are opportunities to do more in-depth training, to get certification. I would really refer you, for instance, to the Academy for Eating Disorders and other professional bodies where you can get that additional training to learn more about eating disorders. One of the positives of the pandemic is I think it also really helped us to expand our access to virtual care. So even if there isn't someone in your community, there's a lot more out there that's available in terms of access to providers that have a broader reach, that maybe have that experience, as well as treatment centers that can be accessed from a virtual perspective. So I recognize that that's a problem. I do not have the solution today, but I implore all of you to continue to educate yourselves, to work on those certifications, and to really look into your virtual options for your patients.
And maybe we can squeeze in one more question in 1 minute. And if we can't finish it, we will provide that information. This one is related to the SCOFF question about weight loss. How to differentiate between intentional weight loss and eating disorder related weight loss, referring to the questionnaire tool about losing 15 pounds.
Excellent question. So the SCOFF is meant to be a screener, and so it doesn't necessarily always correlate with pathology, right? But we want to be able to recognize those patients who might be at risk and then be able to ask those further questions to really get at, was this, an intentional weight loss journey because of lifestyle changes, or is there some potential for disordered eating? So again, that's just a general screener. Hopefully it opens the door to a deeper conversation to really understand what that person's specific risks are.
Thank you, Dr. Williams.
Let's move on to the next slide, please. Here you'll see references for people's review and information for further information for people who would like to read further. Next slide, please. I want to thank everyone for their attendance today. Appreciate how busy your schedules all are in addressing the needs of those you provide care for. I want to very much thank Dr. Williams for her time and expertise in leading this webinar. And of course, my colleague, Dr. Doak, for being available to provide expert answers to your questions. We